pancreas, it will secrete high levels of gastrin. It is the second most common endocrine pancreatic tumor. After the insulinoma, gastrinoma is the next common endocrine pancreatic tumor, and it is common in males. And this gastrinoma is mainly common in a gastrinoma triangle or Passaros triangle. It is called that the Passaros triangle. It is common. Means the points which are forming the Passaros triangle is: one is the junction between the head and neck of pancreas. Next is the junction of cystic duct with CBD. Then junction between the second and third parts of duodenum. So these are the uh, 3 points which forms the Passaros triangle. Then in that area it will be common this gastrinoma. Then what is the clinical features, or what is the result of this gastrinoma? It is like it will cause severe multiple peptic ulcers in the stomach, duodenum, and jejunum. That is, there is hypergastrinemia. So much of gastrin is being secreted, and that will cause high levels of acid secretion, and this will cause multiple ulcers in the different parts, stomach, duodenum, and jejunum. And in addition to ulcers, diarrhea, steatorrhea, hypokalemia also will be present in the patient. Gastrin assay, gastroscopy, USG, MRI, CT scan, these are the investigations which can be suggested. And treatment, 60% it is told as curable. Enucleation of the tumor have to be done. Then distal pancreatectomy can be suggested, pancreatic or duodenectomy, subtotal pancreatectomy, and if needed, so much of ulcers if it is present, then truncal vagotomy it is told. Then other than that, total gastrectomy is also suggested in this case of gastrinoma. Then next is about glucagonoma, that is alpha cells of pancreas. From the alpha cells of pancreas, this glucagonoma will arise. And this is common in body and tail of pancreas. It is common in females. And in this condition, there will be erythema, diabetes will be present, diarrhea, weight loss, stomatitis, anemia. These are the different uh, features present. Investigation same as like the previous tumors, MRI, CT, endosonography, angiogram, glucagon level have to be checked. All these are the investigations suggested. Treatment in the features we have told, there is anemia. So anemia have to be corrected. If there is any deficiency, that have to be corrected by enteral or parenteral nutrition. Then DVT have to be prevented. Then distal pancreatomy, Whipple's or pancreatectomy can be done. Enucleation will not be sufficient for glucagonoma, but still that can be seen. Mainly we will go for this distal pancreatectomy or Whipple's or total pancreatectomy. Then next tumor is Vipoma, that is arising from the D2 cells of pancreas. And this is also called WDHA syndrome. That is, there is watery diarrhea, hypokalemia, and achlorrhea. So it is also called pancreatic cholera. It is malignant. Based on the symptoms being produced, it is getting the other name, WDHA syndrome: watery diarrhea, hypokalemia, and gastric acidity or hypochlorhydria it is told. Then middle-aged females are more frequently involved. And in this condition also, the treatment suggested is, means why it is called Vipoma, it is told like vasoactive intestinal peptide, that is secretion of vasoactive intestinal peptide uh, produced. So because of the intestinal peptide, and WDHA based on the symptoms being present. So due to the secretion of vasoactive intestinal peptides, the cells of islets are afflicted, and this will produce these symptoms, and thus it is named as the Vipoma or WDHA syndrome. Treatment, it is told that resection of the tumor, that is the treatment suggested. So this is the diseases of pancreas as such. Now it is about diseases of spleen. So the basic anatomy, it is situated in the left hypochondrial region. It is held in its position by the gastrosplenic ligament as well as lienorenal ligament. It is a wedge-shaped organ. Then the functions, means it helps in the phagocytosis, neutrophil and platelet removal from hepatic organ, culling of erythrocytes, that is removal of aged or abnormal red cells, that is called the process of culling. Then similarly, the removal of non-deformable intracellular substances are also being eliminated from the body, that is called pitting. So all these functions are carried out by spleen. And we consider the diseases. First thing is about the congenital anomalies. Main congenital anomalies coming under this organ is splenenculi, absence of spleen, splenic cyst, and hematomas. So splenenculi, the single or multiple accessory spleens are present. The common sites of splenenculi, it is told, hilum of spleen, near splenic vessels, tail of pancreas, splenic ligaments, mesochord, and greater omentum. These will be the common sites for the presence of that accessory spleen. Mainly it is in the hilum of spleen or at the tail of pancreas. That is not relevant. And other than that, there will be absence of spleen. That is sometimes with other congenital abnormalities, particularly of the heart, these kind of abnormality may be present, absence of spleen. Then splenic cyst, congenital cyst can be found from the embryonal rest. Then hematomas, that also there are two types of hematomas told, lymphoid hematomas and vascular hematomas. So these are the main abnormalities, congenital anomalies related to the spleen, splenenculi, absence of spleen, splenic cyst, and hematomas. Next, it is means that is not that much relevant, but next point, rupture of spleen, which is an important portion when we take the organ spleen, splenic rupture. So the spleen rupture can be caused by different trauma, or it can be spontaneous also. So the etiology, when we see, one thing is penetrating trauma like gunshot wounds, missiles, stabbings, etc. Penetrating trauma can cause rupture of spleen. Then non-penetrating trauma like automobile accidents, bicycle injuries, blows, various types of sports injuries can result in splenic rupture. Then operative trauma, during certain surgeries, trauma can happen to the spleen and that will cause the rupture. Then another thing is spontaneous rupture. Spontaneous rupture means when the spleen is pathologic, means when the spleen is pathologic, there will be rupture. Means a minor trauma also can cause rupture of the spleen, and mainly it is due to the infectious mononucleosis, malaria, sarcoidosis, leukemia. In these pathological conditions, there is a chance of rupture of spleen. And other than that, when we consider the trauma to the spleen or the rupture of spleen, it is told like it can be a trauma to a normal spleen, it can be a trauma to a diseased spleen, and a traumatic rupture, that is a diseased spleen without a trauma also it can get ruptured. Then spontaneous rupture of a normal spleen, that is idiopathic, the cause is not clearly known. In that way also it is being classified based on how the rupture can happen. These are the four possibilities told otherwise, and we have seen about the etiology as such. And then the pathology, means the splenic injuries can vary from a simple transverse tear to a transverse crack of the hilus also. Means simple transverse tear on the parenchyma, or else it can completely crack the hilus also. And three types of rupture it is told, like acute rupture, delayed rupture, occult splenic rupture. Acute rupture means due to blunt trauma, there will be immediate intraperitoneal bleeding. That is called acute rupture. And delayed rupture means there will be an interval of few days to weeks after the injury, and then there will be sudden intraperitoneal bleeding will start. That is delayed rupture. Occult splenic rupture means when a traumatic pseudocyst of the spleen is diagnosed through injury. So the organ previously has not been diagnosed. In that condition, it is called occult splenic rupture that is being hidden. So these are the three types. And next is the types of splenic rupture. Types of splenic rupture, it is graded, means based on the trauma or based on the how much it is being affected, it is divided into so many, means grading is being done. Grade 1 means non-expanding subcapsular hematoma, then the capsular break is less than 1 centimeter. In the picture you can see laceration is less than 1 centimeter, and that is a subcapsular hematoma is being formed. That is called grade 1. Grade 2 means the laceration is a little bit more, that is 1 to 3 centimeter, and there will be subcapsular hematoma, that too involving 10 to 50% of the surface area. That is more of, when we consider the two images, you can see area of involvement is being increased in the grade 2. That is the second grade. Third one, it can be expanding hemorrhage. More of the part is being involved and laceration is greater than 3 centimeter. Otherwise, there is ruptured subcapsular or parenchymal hematoma. That will come under grade 3. Then grade 4 means there will be the, you can see the hilar vessels. There is laceration of the hilar vessels, and along with that there is devascularization. Greater than 25% of spleen, there will be devascularization also. That is grade 4. Grade 5 means avulsed spleen. There is shattered spleen, and the hilum separation is happening, as well as there is devascularization also. So that is called that is the 5 gradings: grade 1, grade 2, grade 3, grade 4, and grade 5. This image, it is very clearly explained. For grade 1, it is less than 1 centimeter laceration. Grade 2, more than 1 to, means 1 to 3 centimeter laceration. Along with that, subcapsular hematoma is also being increased. Means more of area is being involved. Then 3 means there will be laceration will be more, or else there will be parenchymal hematoma formation. The two conditions will be included in the grade 3. Grade 4 means there will be injury to the hilar vessels or laceration to the hilar vessels, and there will be devascularization. Means due to the laceration of hilar vessels, there is devascularization to the 50% of spleen is happening there. Then in 5, it is avulsed spleen, that is there will be shattered spleen present, and hilum injury along with devascularization also will be present. That is the 5 grades of this splenic rupture. Same thing, table, it is same only. Then how the presentation will be? Presentation, if there is hilar injury, then there will be rapid development of shock, and the condition of the patient will be deteriorating very fast. In if that much severe, if it is affected, that can lead to death also. In other types, features of shock: pallor, tachycardia, restlessness, hypotension, that will be present. Then pain, tenderness, abdominal rigidity in the left upper quadrant, that is based on the location of the spleen. There will be localized symptoms also will be present. Then abdominal distension will be present. Then dullness in the left flank, that is called Balancey's sign. That is there will be dullness in the left flank, means without any shifting, there will be dullness in left flank. Means it is because the collected blood will get clotted. Because of that, there will be a dullness without shifting, and that dullness without shifting is called Balance's sign. And another important sign is the Kerr sign, that is due to the there will be clot collected under the left side of diaphragm, and that blood will irritate the diaphragm, and the diaphragm is being supplied by the phrenic nerve, and the same being supplied in the left shoulder, the phrenic nerve will be irritated, and that will cause pain in the left shoulder, referred pain in the left shoulder due to diaphragmatic irritation. That is called Kerr sign. Then there is another thing called latent period of Bandit. Means, um, what happens is delayed presentation. There will be a delayed presentation. That is initially a temporary localized by the bleeding will be happening, and there will be temporarily localized by the greater omentum. Later the greater omentum will give away, and there bleeding. The blood clot temporary seals of the bleeding, and which will later gets dislodged, and that will give a severe bleeding. In some or the other reason, there will be a temporary stoppage of the bleeding. It can be due to the greater omentum, or it can be due to the clot formation also. But after a period, this will give away, or the seal will be opened, and this time period in between is called, means when there is no bleeding, that time period is called latent period of Bandit. So these are the three important features or terms you have to remember in case of splenic injury. Then if there is other abdominal injuries, that features will be present. Then another Segas is tender point, that is between the left sternum cleidomastoid and scalenus medius, there will be a highly tender point. Severe tenderness will be experienced at that region, that is called Segas's tender point. Investigations: USG abdomen, HB percentage, PCV, blood grouping, CT scan, diagnostic peritoneal lavage, etc. can be suggested. And complications mainly, there will be severe blood loss, then splenic artery pseudoaneurysm, sepsis, DIC, fistula formation, then associated injury if it is present, that related complications also will be present. Treatment: first initial treatment, CVP perfusion, fluid management, antibiotics, catheterization, nasogastric aspiration. These are the initial treatments which can be given. Surgical management: emergency splenectomy, partial splenectomy, splenography. These are the other surgical treatments which can be given. Next is a traumatic rupture of spleen. Without a trauma, what is the means possibility of getting splenic rupture? So it is a rupture of spleen causing hemorrhagic shock, which is not due to any trauma. So it can mimic different kinds of perforation and all. Why the trauma, means why the rupture is happening? It can be due to, it can be a pathological rupture. Means trauma occurs in a diseased spleen like infectious mononucleosis, lymphoma, leukemia. We have already told few other diseases are causing this rupture. Then another thing is spontaneous rupture. Spontaneous rupture means a traumatic rupture of a spleen. There is no trauma, but it can be due to a reflex spasm of splenic vein, or a weak point in the artery, or a ruptured point which is pathological, means that is being destroyed during the rupture, or it is duly means due to an unduly mobile spleen also. So a traumatic rupture can be pathological, maybe due to any other pathology, that without any trauma also it can cause splenic rupture. The next is due to spontaneous rupture, that is without any cause. In a normal spleen, that is being happen. So what it is, because of a reflex spasm of splenic vein, or if there is a weak point in the artery getting ruptured, or ruptured point which is the only point pathological that is destroyed during rupture, or due to unduly mobile spleen. That is the atraumatic rupture of spleen. Before we have told about the traumatic rupture, this is about atraumatic rupture. Now about the cyst of spleen, it can be primary or secondary cyst. Primary is again divided into parasitic and non-parasitic. Secondary is divided into pseudocysts, mostly due to infections. So clinical features that can be vague signs and symptoms, and mainly it is about the pressure effects. The cyst creates pressure on various adjacent structures, and because of that pressure effects, symptoms will be produced. Treatment is aspiration of cyst, or else splenectomy can be done. Then about tumors of spleen, usually malignant lesion like sarcoma, angiosarcoma, or lymphoma can form. Then metastasis is rare, but in case of Hodgkin's and non-Hodgkin's lymphoma, the metastasis to spleen will be happening. These are the two conditions where the metastasis is happening to the spleen. And another thing is hypersplenism, that is increased splenic function. So hypersplenism and splenomegaly should not be confused. Hypersplenism means there will be increased splenic function, and the peripheral cytopenias and reactive bone marrow will be there, and they are divided into two, means primary hypersplenism and secondary. As you know, there is no cause found. Secondary means there will be an underlying cause. Primary hypersplenism, there will be fever, frequent infections, oral ulcerations. When we do the peripheral smear examination, we will know, means due to that increased splenic function, there will be peripheral cytopenia. So that will be evidence from the peripheral smear. Treatment, we can give corticosteroids. And in secondary hypersplenism, it is due to work atrophy, means work hypertrophy, or secondary to some other pathologies like Gaucher's disease, Felty syndrome, and all. This secondary hypersplenism may develop. Splenic abscess, it is uncommon, but it can be fatal. Means it can be caused secondary to any other infections, endocarditis, AIDS, polycythemia, sickle cell disease. In secondary to any other conditions, this can develop. Usually, it is caused by Streptococcus, Staphylococcus, E. coli, Candida albicans, etc. It is an abscess condition, so the clinical features, it will be fever, pain in the left hypochondrium, pain in the left chest region, left sided pleural effusion. Spleen will be palpated, means when it is palpated, there will be tenderness in the area. Investigations, you can go for USG, ESR, CT scan, etc. Then treatment, antibiotics can be given, ATT and can be given if it is needed. And then it is splenectomy. Splenic artery aneurysm means first main site of aneurysm is abdominal aorta. Next, it is the splenic artery. It is common in females. It can be caused after an episode of acute pancreatitis. Treatment, it is told, splenectomy along with the ligation of the aneurysm. Then embolization also can be done in this case of aneurysm. Then splenomegaly, enlargement of the spleen, and that can be due to multiple causes. It can be due to blood disorders, it can be due to infective disorders, neoplastic disorders, circulatory disorders, cysts of spleen, and miscellaneous like Gaucher's syndrome, Felty syndrome. These also can result in splenomegaly. So when we consider splenomegaly, it is like the cause, means the splenomegaly is just a symptom, means it can be present associated with different kinds of other underlying pathology. So first the cause have to be identified, and based on the cause, means for that all those investigative blood investigation, CT, MRIs, USD, all those can be done. And first we have to end up in a diagnosis, and based on the diagnosis, what is the underlying pathology, that have to be identified first, and based on the underlying pathology, we can go for the treatment. That is the investigations as well as treatment, just depending on the means what is the underlying pathology. Based on that, the symptoms will be manifested, and based on that, investigations have to be suggested, and finally we have to end up in a treatment according to the underlying pathology. Clinical features of enlarged spleen. There will be mass in the left hypochondrium. A notch will be felt. Then it will be moving with respiration. On percussion, it will be dull note. Hook sign. That is when we are palpating, means that it while palpating the spleen, we can palpate it through the costal margin. But in this, when the enlarged spleen is there, that hook sign means we cannot insinuate the fingers under the left costal margin. That will be happening when the uh, spleen is getting enlarged. Otherwise, normally we will be insinuating our fingers through the costal margin, and thus the spleen will be palpated. That cannot be done in case of enlarged spleen. The fingers cannot be insinuated into the left costal margin. And the treatment, splenectomy, all these conditions, we can go for splenectomy whenever, depending on the condition of the patient. And first we will try for conservative management, and then next option, in all those conditions we can go for splenectomy. It's indications of splenectomy. If we take all those conditions told under the heading of splenomegaly, that is the same indications for splenectomy. Then procedure, incision. Means incision, it can be left paramedian incision, it can be midline incision, left upper paramedian incision, or thoracoabdominal incision also. Thoracoabdominal incision, it is rare. And next is we have to mobilize the spleen. Then the gastrosplenic ligament as well as the splenic vessels have to be divided, and that they have to be ligated. And the spleen means, in case of ruptured spleen, the vascular pedicle is clamped and it is divided. And then if there is accessory spleen present, that have to be divided and ligated. And then the spleen will be removed. And if it's a proper inspection is told, inspection of the wound and closure, that is after splenectomy, the ligature of the vessels of the spleen and the gastrosplenic ligaments are checked. And if there is any small oozing, that have to be tackled with a religature. And the tail of pancreas should be carefully inspected. If it is lacerated, then there is chance that there will be wound disruption. So after doing the procedure, after the means we have incised, we have done the mobilization of spleen, then the ligaments as well as the vessels then again proper inspection of the wound, and then only closure should be done. Any kind of oozing, any slip of ligature, all those have to be seen. Otherwise, there will be chance of wound disruption. And when there is no oozing inside the wound, and if the tail of pancreas is not injured, then drainage is not necessary. And if there is any oozing, or if there is any damage or injury to the pancreas, tail of pancreas, then we have to do the go for drainage. And next is about the overwhelming post splenectomy infection. That is due to that, we have told it is one among the organ which is involved in the immunity process. So because of the decreased amount of IgM in the body, there will be increased risk of infection. That is 2 years after a splenectomy, it is common. The infection, the features: fever, chills, sore throat, hypotension, shock, respiratory distress, etc. And for that prevention and treatment, it is told that we can go for pneumococcal vaccine post surgery, then anti-malarial prophylaxis, antibiotics, then immunoglobulin transfusion, blood transfusion, etc. These can help in prevention as well as treatment of this post splenectomy infection. Because of the amount decrease in the amount of IgM in the body, there is a chance of high risk of infection. So that can be prevented by these kind of methods. That is about the diseases of spleen. And when we or any references we can see in the Medakshaya, it is told Pliho Vritti Krishanga, that is told in the Pliha Vivritti, it is told in the Medakshaya context. Then Pliha Vritti, it is told, means due to Ashitasya Adi Sanshobha Dhyanayanaati Cheshtade, because of vigorous movements, because of increased intake of food and all, it is told that the pliha, the Vama Parshvasrita pliha will be displaced from its place and it will be increasing its size. Vama Parshvasrita pliha Chudasthanat Pravartade. There will be displacement. That is, it is from the normal anatomical position, it will be displaced and there will be increase in its size. That is told. Then Vama Parshvasrita pliha Nadi Vishesha. It is told about the Lakshana. It is told like pliha Kadino Ashtilava Ashtilavadau Vardhamana Kachava Santana. That is, it will be hard, it will be this resembling a covering of the tortoise. That much big it will be, and that reference is there regarding the Pliha Vritti. And another thing we have to see is about the Pliha Udara. That is in detail. When we see the Udara chapter, we will be discussing about Pliha Udara in detail. Other than that, these are the main references which we will get regarding Pliha or Pliha Vritti. Mainly it is in the Medakshaya. Then Pliha Vidradi, it is told in while explaining about the Abhyandara Vidradi. In the context of Vidradi, Acharya is telling about Pliha Vidradi. Pliha as a sthana for Abhyandara Vidradi, and there it is told Uchvasa Avarodha will be there when there is Vidradi occurring in the Pliha region. So that is the references regarding main. It is in the syllabus also. It is main about the Plihodara that we will be discussing in the next class. It will be about Udara. It is exclusively on Udara. So in that we will discuss about Plihodara in detail. It is told in Medakshaya as well as in this Pliha Vidradi also there is mentioned. So diseases of spleen, you can write about that also according to the question asked. So that is about diseases of pancreas and spleen.